In this case, because our previous speaker have talked about the different technology and also the tools to tackle the malaria as well as to eliminate the malaria in this world. So from this point of presentation, I'd like to focus and make emphasis on the how are we going to deliver, the model of care delivery model for the malaria elimination. So why community engagement and access to the service at the grassroots level is important? So this is a fundamental question that we should ask when we are delivering the malaria services to in the community level. So as you are aware, that malaria is a rare disease, and today the global malaria burden has declined significantly. But in this world, especially focusing in a Southeast Asia country, the malaria map is shrinking. But the thing is that although the general malaria burden is declining, there are some focal hotspots in the country which still have the malaria has local transmission. So these pocket areas are often geographically and socially hard to reach population, hard to reach area. So because as you are aware that over the past decades, then malaria program has been targeted in most of the area, but especially easy to access area. So that means that there are still gaps remaining in the really hard to reach, not especially the geographically hard to reach, but also the politically, socially hard to reach area. So these pockets can be touched without the engagement of the community. So because if we cannot make special engagement with the community, then we cannot reach and we cannot effectively eliminate the malaria in this pocket area. So we have to remember that if we want to eliminate malaria, we cannot leave any single spot in a malaria endemic area. So over the past years, then malaria has been tackled by different expertise and the different organizations and different government with different models. So if we look back the different models that we have been developed and used, then we can see that there are government health model. So here I mentioned that this is mainly for the malaria service delivery. So people use the government health facility-based model. So most of the malaria services has been delivered through the government health facility. And the other one is about the non-government model. So as you may aware that in many malaria endemic area, NGOs and the malaria implementers open their own clinics and then they provide the services through their clinic. Apart from that, when we talk about the malaria service provision and the malaria elimination, we should also encounter or we should also think about the private sector. So here, there are also established private sector, mostly are the GPs and private doctors working in the community. So these people are also involving in a critical role in providing the services. So the last one is the community delivery model. So a number of studies and paper has been developed and published that the use of the community delivery model. I'll come up with this model a little bit more later. So as you may be aware that not a single model is perfect because each and every model has their own problem as well as their endeavors. So if now in these days, the community delivery model has been more and more popular because of their proven effectiveness and efficacy in the malaria endemic area. So if we look at the community delivery model, community health worker, so in here we abbreviate the CHW are the key players. So CHW are they are the members of the community. So they are not from the government, they are not the government staff, but they are the community members, and so they have been recruited by the community, by the implementing partner or the government in consultation with the community. So they are answerable to the community for their activities. So they are normally trained and supported by the health system, but the important thing is that they are not the permanent staff of the health system. So again, if we look at some of the barriers and enablers that has been researched and identified of the community delivery model, so one of the barriers is the over-exploitation of the community of the services. For example, like in a number of settings in Africa as well as in Southeast Asia. So the organization has trained the community health worker mainly for the malaria services, but the real thing is that the community expects more than the malaria from the community health worker. This is one of the demand and the supply issue. And the other one is about the community norms and the perception and service utilization. So although we try to deploy the community health worker at the village or the grassroots level, there are still norms and the perception of the community that tend to use the non-trained provider like the quacks or the village touter. So the other problem is about the attrition of the service provider at grassroots level. So although we train this provider in the community level, then the attrition is very high in some of the area. The other problem is about the lack of the minimal contribution of the community. So the sustainability of the service provision model is also an important issue here. So mostly the community health workers expect the monetary or the non-monetary contribution from the community, but sometimes it didn't happen. Well, they are also experiencing the stock-out problem, especially at the grassroots level. So this became this make community health worker betray from the guidelines or sometimes depressed in front of the community member. Well, this is not only about the problem. Because of the community health worker and the community delivery model, we also have enablers and the endeavors because of the model. So one of the successful factors of the community delivery model is that we can see the visible result or the visible achievement at the community level. So if a community member or the villagers get a malaria, so we can do spot diagnosis and then we can treat them even at the village by using the RTT and the ACD, now even applied to the community health worker. And the other good thing is the trust of the service provider, which is because they are coming from the community and not a stranger. So we can also develop in some of the settings, the community trust has been developed between the provider and the community. So cost effectiveness is also one of the good things about the community delivery model. So if one of the studies has identified the community delivery model is twice cost effective as the government service facility-based delivery model. And because of the health system recognition, they can implement the malaria services very well. So in this context, if we look at the ICMV of Myanmar, then as you know, that Myanmar is one of the Southeast Asian countries, so as well as a Greater Mekong sub-region country. So up to now, Myanmar has still contributing the highest malaria burden in the region. So as the previous speaker presented, the drainage system problem is still there in Myanmar. And as I mentioned earlier, at-risk population include migrants and the forest workers who are geographically, economically, and socially hard to reach population. And it is critical to eliminate malaria from Myanmar because to prevent the regional and the global tragedy. So a number of speakers has already identified the border malaria and the documented and undocumented migration. So there are lots of documented and undocumented migration happening between Myanmar and Thailand, as well as Myanmar and the Yunnan province of China. And so the thing is that although the other regional country has been progressing a lot for the malaria elimination, but if Myanmar is not progressing well, the regional elimination goal will not be achieved. So that's why the Asia-Pacific head of government agreed to eliminate the malaria from the Asia-Pacific region at latest on 2030. So if we see the malaria trend of Myanmar, then it has been declining significantly even year by year. And so if you see the blue bars, those are the confirmed malaria cases diagnosed by either RTT or the microscopy or PCR, but the major contribution is the RTT here because starting from last decade, Myanmar has started using the community health worker, and so we equip the community health worker by RTT, and so they can do the malaria diagnosis at the community level by using the RTT. So today, malaria is still a focal disease in Myanmar, but the real challenge is how are we going to test these focal areas in Myanmar? So if we see the paradigm shift of the Myanmar malaria control model, so before, in 20th century or the 15 years back, then the government health facility are the main service provider for the malaria. But starting from 2003, there are lots of NGO has been landed to Myanmar to contribute in the malaria control model, and so lots of NGOs and the private GB has been trained and providing the malaria services. Well, starting from 2004, we started using the CHW community health worker models in Myanmar, and so if you see the graph, then the malaria decline has been very significant starting from the last decade in Myanmar. So now we are heading to the malaria elimination in Myanmar because we already agreed to eliminate malaria in 2030. So the target is to eliminate malaria in 5 provinces in Myanmar before 2020, and another 5 provinces in 2025, and the rest of the province in 2030. So here, starting from next year, 2018, then a new model has to be deployed in Myanmar, so which is called the Integrated Community Malaria Volunteer for a couple of reasons. So before going to the Integrated Malaria Community model, then I'd like to explain a little bit about the community health worker model in Myanmar. So it is the community health worker in Myanmar provide the basic malaria services of malaria, which is they have been trained by the government or the implementing partner. They have been equipped with a number of commodity for the malaria, and they provide the diagnosis and the treatment according to the national guideline. And they do the behavioral change communication and the health education at the community level, as well as they involve in the community mobilization and the benefit distribution campaigns. So I think those are more or less similar, but there are some context-specific barriers and enablers of Myanmar. So I will just highlight some of the context-specific. For example, like because of the civil war in Myanmar, then although we try to deploy some of the community health workers in Myanmar, then we can do right now for the political reason and also the civil war. So, well, the other thing is about the motivation and the role of malaria CHW. Because of the declines of the malaria prevalence in Myanmar, the role of the community health worker has also been declined. Because in the villages, they used to be the very important person in the villages because most of the illness in the village are malaria, and so when they come and see the village volunteer in Myanmar, then they get tested and treated, and so they recover from the illness. So they were very important person in the village before, but now the problem is that the problem has been declined and their role has also declined. So this is one of the issue, and the other thing is the inconsistency of the training package of the village volunteer. The next thing is about the according to the shifting of the control to the elimination model, the test and the specific force of the village health volunteer has also been changed. For example, like previously, they're just doing the routine testing and the diagnosis and the treatment, but now they need to do more works for the malaria elimination. So those are the changing challenges. And most of the enablers are more or less the same, like the community trust of the service provider, volunteer spirit, recognition of the health system, and the multiple partner engagement. So the new model is the integrated community malaria volunteer. Here, these malaria volunteers have to do the basic malaria services as they used to do before, and not only the malaria-based services, they also need to do the elimination test for like the hotspot identification, the household mapping, and the community mobilization for the elimination task force, so those kind of stuff. And the last one is not only the malaria, we also trying to use the community health workers for the other diseases like the tuberculosis awareness, and also the HIV awareness promotion, as well as the other vector diseases like the filariasis or the dengue community activities. So after combining those components, then we try to create the integrated community malaria volunteer model in Myanmar. So as a conclusion, it has been proved, and now people are still using the community delivery model, one of the cost-effective and useful model for the malaria elimination. And one of the other recommendation is about the advocacy and consultation with community members before starting the planning stage, so that we can know what the community requirement and how are we going to adapt the program, so that not to conflict even after starting the program. And regular consultation with the local stakeholder and adaptation of the program is still needed even after starting our program. Otherwise, a number of before in the program implementation is the donor-driven project, and the community engagement is sometimes going in different direction. So the last one is about the operational research. Yes, we need the operational research to modify our model, as well as to develop the effective tool for the elimination. Thank you.